thanks very much. Thanks to all of you again. We're going to walk through the data, and we need to really thank Nora and Ella, but particularly Nora, for all of the work she has done on this for us. We have about 60 slides. Jane and I are going to tag team it, and whilst one of us is speaking, the other is going to try and fill the chat. So we'd encourage you to ask any questions as we go, and we'll try and address your questions as we go if we can. Okay, so we've already heard about the optimal care pathway, and I'm sure that's very familiar to most of us who are online. And this really frames the structure of how the data is being presented. The data that we have is based on multiple data sources, which are in front of you now: Victorian Cancer Registry, hospital admissions, emergency presentations, radiotherapy data, and there is some VINA data, non-admitted data, and then, of course, we have death data. You'll note that the data we have spans different years, and so I would just encourage you, as we walk through the slides, to look to the top of the slides, because that will inform you which years and which data set are captured in the information on the particular slide. And, of course, there's unlinked data source from the CSPI. A couple of things to say: we've got statewide data here, but there are some limitations to the data. So we've got breast screen data, but we don't have data from patients who have screening performed in the private setting. We don't have MBS or PBS data. So there is a lot of absent data with regards to drug therapy. And we really don't know what is happening out there in the community. A lot of the data requires hospital coding. So a lot of this is really requiring a code for a patient to be admitted, whether it be for an admission for treatment or admission for surgery or radiotherapy. And we really do lack data on recurrence and the advanced setting. Also, just to say, from Hume data, there is some gaps there with regards to whether patients cross the border into New South Wales or those New South Wales data participating in Albury. I'm sure you know your ICS, but you may not know everyone else's ICS. I certainly am not very familiar with this map, so just maybe a few moments for you to have a look at the ICS map. And as we present the data, as you'll see, many of us on the working party have seen this several times. And what we'd like to do, if you haven't seen the data before, or certainly if you've seen it, is think about where the variations are and how we can improve data collection within existing structures. And what data is not here for you, that I guess one key thing we've been thinking about is, if we were doing another summit in 5 years' time, what data would be really crucial to have, because that will help inform better practice. And does clinical practice reflect the optimal care pathway? So they're the kind of features we want to think about. These are the topics we're going to go through. As I said, I think Jane's going to kick us off with the first part, and then I'll come in towards the end. Thanks, Jane.
Thanks, Belinda. So we're really going to start with, I guess it's data. So there's a series of numbers, and we certainly know a lot about diagnosis and most of the initial treatment. So that when we look at the incidence both of invasive breast cancer and of ductal cancer in situ, we know that this is a common cancer in women. We know that it is in part a disease of affluence, and that we're treating the majority of women who are very well in, I guess, what would be referred to as kind of late middle age rather than elderly. And this is really just showing us that there is an almost linear relationship between advantage and the incidence of breast cancer. Male breast cancer obviously forms a small number of the patients that we treat. It tends to occur in a slightly older age group, similar socioeconomic status, and the majority of men diagnosed with breast cancer are well. But there are some more comorbidities given that slightly increased age. And we know that about 1 in 100 breast cancers is diagnosed in men, and the numbers that we've got support that that's what's happening in this period in Victoria. So moving on to the diagnostic pathways for both invasive breast cancer and DCIS. We know that when we look at female breast cancer and we look at the stage of diagnosis, the majority of breast cancer in Victoria is diagnosed at an early stage. So with a smaller number of loco-regionally advanced disease. And the only statistics that we've got about metastatic breast cancer are really the number of women that are diagnosed and have metastatic cancer when it's first detected. So we don't have the statistics about women who are treated and later relapse. And I think that's been highlighted by our consumers as a really important gap in the data. Interestingly, there are 10% of patients, so something over 1,000 patients, where we don't actually know the stage at diagnosis. And for those people who aren't aware, the Victorian Cancer Registry collects staging data for breast cancer, but not for all the other breast cancers. And there are a number of reasons why we may not know the stage related to when cancer is actually notified, what information's available. And we also know that we'll move on a little bit later. We think that something of the order of 10% of women are having neoadjuvant therapy prior to surgery, and so that's probably blurring the staging data. When we look across the state, we're seeing very similar numbers across the ICS. We're not seeing wide variation in the stage at which people are diagnosed, which is reassuring in terms of people living regionally. There are some differences between the ICS in terms of socioeconomic advantage, but generally most people are close to the state averages for their stage at diagnosis. And again, you can see that a small number are diagnosed with metastatic disease de novo, but the vast majority have stage 1 or stage 2 disease. And so the intent of treatment then is certainly curative. Looking at this data about screen-detected cancers, now we only have the data for Breast Screen Victoria, so we don't have the numbers that are diagnosed by informal screening, which we know is actually fairly prevalent. And as you might expect, if you look at the paler pink, that's the Breast Screen Victoria detected cases, and we're seeing about 20% DCIS in the screening population, which is a very consistent number over a number of jurisdictions and a long period of time. And as you might expect, with more advanced cancer, it's more likely to be symptomatic and less likely to be screen detected. So of the screen detected cancers, the majority of them are early stage, again, as we might have expected. So this is really comparing the ICS of residents of the people who've been diagnosed. And you can see that there is a variation, of course, in terms of the numbers of women diagnosed. So there are smaller numbers diagnosed where there are smaller populations. And again, those numbers are remarkably similar across the state. The grade at diagnosis, we know that the vast majority of women diagnosed with invasive breast cancer will have grade 2 disease, and that's certainly reflected in the numbers. And DCIS, when it's detected by screening, tends to be intermediate or high-grade DCIS, given that low-grade DCIS is often diagnosed incidental to other pathology and often doesn't have any imaging abnormalities. Again, it's of concern that we're looking at 14% of invasive breast cancers that the grade is unknown, and about a third of DCIS patients where the grade is unknown. So there's some definite gaps there. Again, I think there's probably no real surprises here in terms of the distribution of grade in screen detected versus non-screen detected. There's a little bit more high-grade cancer in the non-screen detected population in terms of invasive breast cancer, and more high-grade DCIS in terms of screen detected cancers. Again, significant numbers with no grade recorded. So we've got a little bit of data about male breast cancer. The majority of male breast cancer is actually invasive breast cancer at diagnosis. a small amount of DCIS. And again, these are usually grade 2 or grade 3 tumours. Again, a quarter of them don't have a recorded grade, which is probably a little bit surprising given that male breast cancer is almost always treated by surgery up front. Again, no surprises here in that the vast majority of our patients actually have luminal A or luminal B, so estrogen receptor positive cancers. The fact that about 12% of our patients are HER2 amplified, there's a little bit of difference between the numbers here around when the cancer registry records HER2 amplified, they're actually looking for an ISH result as well as an immunohistochemistry result. And there are some patients who've had immunohistochemistry, which is 3+, but no ISH recorded. But that number of about 12%, I know a lot of us actually estimate HER2 positive disease to be higher at about 20%, but the reality is that it's a bit lower. It's somewhere between 12 and 15% in most populations. And again, triple negative breast cancer is a relatively small number of cancers, but obviously very important in terms of treatment planning.
There were a couple of questions around the issue of no grade for the cancers and DCIS and where that gap falls. And I think Carolyn's made a comment. It's based on the VCR data, so it comes from the pathologist report.
And some of our thoughts about it, that's something that the group have discussed at some length, and it's not clear to us what's happening there. We know that some pathologists are reluctant to grade on a core sample because of the possibility of sampling error. There may be some pathology reports where the initial pathology report is submitted and then subsequent pathology is not actually submitted and collected. And it's certainly something that we feel should be explored.
Yeah, and I think that neoadjuvant issue, that obviously there's not a grade at the end of any preoperative therapy. And so if that is being submitted, there won't be a grade recorded for those.
The other thing that has been suggested for some of these patients that aren't graded is if a diagnosis is made on a biopsy of a metastatic deposit, whether that's nodal or distant metastases, then grade won't be recorded on metastatic. So if there isn't a biopsy of a primary tumour, we won't be able to grade it. So this harks back to what our consumers were talking about to some extent. What we're seeing here is the multidisciplinary meeting participation. And what you can see here is actually a very wide distribution across the state, with some particular sites having a lower incidence of multidisciplinary discussion about patient management. These numbers actually come from an audit that was done by ICS, and what they were looking for was really a written summary of recommendations located in the patient's medical record. So it's really not only about having the MDM participation, but it's also about actually recording the results of the MDM meeting, and that really feeds into the plan for patients being treated. And that's something that warrants more discussion. It's actually quite interesting to reflect on the fact that these are 2018 figures. What actually happened in 2020 and also through 2021 is that many more people have had an online platform for their MDMs, which potentially allows much greater participation than people have previously been able to have in more remote areas. So the next section is really looking at breast surgery. And so as we might expect, the majority of women with early stage disease are having breast conserving treatment. And that's really been pretty stable for a long time. And we don't have anything that would, for instance, measure the impact of oncoplastic surgical techniques in terms of increasing the number of people who are able to have breast conserving treatment. And I think it's something to sort of watch going forward. When we actually move on to patients with stage 2 disease, we're seeing a greater proportion of mastectomies, and we're seeing a high proportion of mastectomies in those patients presenting with stage 3 disease. Now, this is obviously quite an interesting group because depending on the phenotype of the tumour, we would see more women in that group actually having neoadjuvant therapy of some form, usually chemotherapy. And one of the discussions that we have as surgeons is that we can use neoadjuvant therapy to downstage a cancer and then potentially to change someone from a mastectomy to breast conserving treatment. And it would actually be great to have a little bit more data about where patients were starting off, what treatment they were having, and then what operation they were able to have. There are small numbers of patients with stage 4 disease having surgery, and it's about evenly split between breast conserving treatment and mastectomy. We don't actually know whether those patients are patients who had surgery for what was believed to be early stage disease and then had metastatic disease diagnosed because of imaging after surgery, or whether there are also some patients there who may have had surgery to achieve local control even in the presence of metastatic disease. And again, we've got our group of unknown patients. It's that same group of a little over 1,000 women. There's a couple of questions here.
Wang's asked about the issue between IHC3 plus and the amplified patient. So look, we've put both of that data up there, but obviously we know an amplified patient is considered amplified, and a HER2 3 plus, I guess, outside of Australia is actually considered positive, but in Australia, to get access to the antibodies, you need to show an ISH. So there is some small but very real discordance between 3 plus and amplified, which is a little bit of a worry, but we haven't really gone through that. Just to reassure you that it didn't change the numbers terribly much. Ian Collins has made a comment about the MDM audit. There were issues with the audit in terms of where they were looked up for the record of the MDM. That's one issue. It's not just, and you pointed that out, Jane, not just a record of whether the patient was presented, but then that information needed to be put into a file. And I guess if a patient's having treatment across multiple sites, the question is where that information potentially goes. Is there a difference between breast conserving surgery and mastectomy in metro versus regional?
We've got a little bit of data on that later on, but no, not particularly. And I think that probably reflects the fact that radiotherapy is much more widely available across the state. I think the issue of auditing the record of the MDM is true, like it was a case record review, which is always slightly complicated because there's lots of things entered in a medical record. And I think those issues are not only where was it recorded, but who was it shared with, and particularly was it actually shared with the patient for whom the plan is being developed. So I think that's something that needs to come out a little bit further. Josh has commented that patients' wish plays an important part in their surgical decision, and that's certainly true. I guess I'd make the comment that the decision needs to be informed. There's some actually interesting data outside this meeting about the choices people make about DCIS treatment and how well informed they are about risk and benefit of choosing different things.
And Collins made a comment that the MDM record doesn't actually show time continuity, so it's possible that treatment may have started before the MDM discussion. There's lots of nuances with that.
I think most surgeons would acknowledge that there are a number of patients with early stage disease that won't have an MDM discussion until after they've had surgery because of the surgical pathology either informing that discussion or actually just not being a practical thing to actually do an MDM and then organise surgery. So our next slide is really referring to the type of axillary surgery that people would have had. As might be expected in early stage disease, the majority of people are having sentinel lymph gland biopsies, and Again, we've got those small numbers of stage 4 disease where it may be diagnosed post-operatively. There are some patients having sentinel node biopsies with DCIS, and we think that that's probably a cohort of patients who are either having mastectomies for DCIS when we know that we can't go back and do a sentinel node effectively if we need to, or patients who've got other features on their DCIS where it's more likely that the final pathology is going to disclose invasive cancers, such as those who've actually got palpable DCIS. And so I think that we're really seeing here appropriate management of the axilla when people are diagnosed with invasive breast cancer and, in fact, with DCIS. This is where we get into the hundreds and thousands game, because on the funnel plots, each X has a dot for each institution. And so you'll see that most of the X's have actually got scattered dots indicating the various campuses where people have had treatment. And I know that everybody's looking and trying to collect their X dots with their eyes and work out which particular hospitals are actually included. And I think that's, obviously we think that's work that individual X, can actually have a look at. What we're seeing here, and this has actually been modified in keeping with the new optimal care plan data. So we know that the vast majority of patients who are having surgery as their first therapeutic intervention will be treated within 5 weeks of their diagnosis. But you can see there on the graph that we're actually looking at very different performance when we look at private hospitals versus public hospitals. So that almost 100% of patients treated in private hospitals will have surgery within 5 weeks, and it's much lower within the public hospital. As we go up to 35 days and 40 days, that actually gets much better. But for a variety of reasons, that's not being achieved. And obviously, diagnosis for the purpose of this discussion is the time at which the cancer registry is advised that the cancer has been diagnosed. So that's actually usually the first core biopsy, which may be through the screening program, it may be through a diagnostic process. So there's some variation in the way that patients are being diagnosed, but there's clearly also some variation in access to care. This is really, I guess, reflecting the fact that across the state, the vast majority of people are able to have surgery close to where they live. This slide obviously looks at mastectomies, and it's comparing the X of residence across the top with the X campus of treatment down the side. And what we're seeing here is most people having treatment close to home. There are probably some people choosing to travel either because of family support or access to close accommodation, but generally it's, I think it's a good result. This is an interesting slide because it's showing us that there is quite a lot of variation. There are a small number of both private and public hospitals which do a low volume of breast cancer surgery, both mastectomy and breast conserving surgery. And in other tumour streams, this has been concerning because we know that in some cases the outcome of treatment where it's a small volume hospital is less good than where it's a large volume hospital. But what we think is happening here is that is not necessarily reflecting a lack of facility or a lack of clinician expertise or a lack of access to breast care nurses. But it does raise the issues of saying, are there different experiences in terms of where people are being treated? And obviously we don't have good measures of how that goes. We don't routinely use patient-reported outcome measures in the state, and they've proved to be quite difficult to implement. And so although this is small numbers, it would be reassuring to know that the experience is appropriate for the consumers. There's a few more comments coming back through the chat that there is the issue of people having multi-campus treatment and maybe multi-ICS treatment, and how information is shared across those sites, with the question of paper medical records versus electronic records, or electronic records of at least the multidisciplinary discussion that can be shared across. Debbie Nielsen has pointed out that patient choice can impact time to surgery, and I think that's a really reasonable comment to make, particularly when the urgency of surgery, or the urgency of treatment rather than surgery, may vary a lot from person to person. And there are also ways of temporising patients having treatment.
Shard's brought up a point about the MDM. Is there a minimum acceptable multi-specialist presentation? For example, do you need more than one oncologist? I don't think we've got specific guidance around that, but I guess we know that you're more likely to get evidence-based care if there are multiple people in the room with the same specialty, but perhaps that's not clearly stated. Do you know, Jane?
No, I don't know the answer to that. I mean, it does seem that you certainly need to have the disciplines represented, and we know that there's an effective number of people who can have a discussion.
And Z Wang's asking about age variation about recon between metro and regional.
We'll come on to the recon data. There is a comment here about surgery being delayed because an individual had chemotherapy first, and I guess that's a data gap that we'll come back to because of this increased use of neoadjuvant therapy. So in this slide, we're really actually talking about patients who had surgery as their very first treatment. There will be other patients who have chemotherapy as their very first treatment. So having chemotherapy up front is not measured as a delay to surgery. So what we're looking at here, we had quite a bit of discussion in the group about this, is reconstruction rates. And the first thing that we should point out is the fact that reconstruction rates in Victoria are very high. The national average is 11 or 12%. And so the access of women to reconstruction in Victoria is really very good. Now, the only thing that we're really measuring here are patients who have reconstructions within a year of their diagnosis. And we don't have a way of collecting data around those patients who have late delayed reconstructions by choice or because it's available. As you might expect, there is more reconstructive surgery done in the metropolitan area, and I think that's really predominantly related to reconstructive resources. But we know that, and we'll have a look at another slide in a minute, we know that people in fact are travelling for reconstruction. So the reconstruction rate is certainly lower in the regions. The other thing that we looked at was the age, and there's a very clear division between women accessing reconstruction under the age of 65 compared to over the age of 65, and that's perhaps not unexpected. And this is really talking about the fact that we've only got limited data. So the majority of patients having reconstruction in our state are actually having it during the same admission as they're having their mastectomies. There are a smaller number of people where it's actually within 12 months of their diagnosis, and some of them may be neoadjuvant patients. And we've got a little bit more travel after 12 months, again, more from the regional centres, perhaps for delayed reconstruction. And this is really similar data in terms of where people are having their reconstructions. So we know that the ICS of residence and the campus where you have your reconstruction, again, people are more likely to travel to well-resourced large institutions to have reconstructive surgery.
And there was a comment from Catherine saying, certainly more time, being reassured that they had decision time and that it wouldn't impact on their outcome is important. And I think that does highlight, this issue between this KPI, so to speak, that's built into this must have surgery or start treatment within a certain amount of time. And yet really, does that actually make a difference to overall care? And we certainly know, at least in ER-positive disease, that actually longer time to make that decision does not impact on survival. So that's reassuring. Here we go, Sue. We are missing clinical stage at diagnosis for a number of reasons. Women have had neoadjuvant, cannot be staged. Well, I guess cannot be is difficult. They should be staged. They should be staged clinically. They should have a clinical staging. But you're right, they don't have a pathological staging. But certainly they should be clinically staged. Second, we do not get good data staged from hospital notifications coders because of poor documentation in the medical record. I am not surprised that's the case, Sue. And we do not capture imaging data in the VCR. Some women choose conservative management or alternative treatment to surgery after imaging. So I guess you're referring perhaps there to patients who don't have surgery but do have a diagnosis based on a core. Yes, that's true. The COVID impact for immediate reconstruction, comment from Rue in Shep, and a question from Debbie, would upfront PET scanning help with staging? So look, we do know that there's a significant role for PET. What hasn't been convincingly shown is that a PET adds additional information to standard staging such as bone scan and CT, but there are certainly some instances where PET does provide additional information. I guess one of the great benefits of PET is that you only need the one scan instead of having two, and that has some substantial advantages. The difficulty is it's not completely staged for the brain. A PET's not great for the brain, and obviously PET scanners are nowhere near as abundant as CT scanners and nuclear medicine bone scans. But certainly there's a lot more PET happening since the MBS criteria from, I'm going to say, the end of 19, but I might have that wrong.
I think the other thing that's actually important, and certainly the working group, we don't believe that people aren't being staged. What we believe is that the staging is not being captured. And obviously, you know, the Victorian Cancer Registry is dependent on the histology. That's the only way that cancers are actually notified. And then, as Sue's pointed out, then the question is, where does that information come from? And I think most people would know that unless someone's written in the history, and that will usually just be not in a database format, it'll be in a medical record format that's not searchable. You can't get the electronic information out of the histories. So I don't think anyone's not doing the tests. It just isn't possible to get the information in a way that we can use the data.
We've got some data about treatment, but it really is only capturing chemotherapy use, which is a small part of what we do in breast cancer. But regardless, the reason we have this data is because you are admitted for your chemotherapy. And not surprising, I guess the higher stages are more likely to receive chemotherapy. Interestingly, 20% of stage 1 are actually receiving chemotherapy. So I think we have a lot of work to do there. We do have some stage 4 diagnoses, and these are the de novo that have been recorded, and half of those are getting chemotherapy. And we do believe that the stage unknowns are largely representing neoadjuvant patients, although we obviously cannot be absolutely certain about that. So in terms of timing, we're not doing terribly well to get chemotherapy on time, or certainly as suggested by the optimal care pathway. So about 20% of patients are getting it within 4 weeks of their surgery. That goes up to nearly 70% at 6 weeks. And we've looked at this in terms of tumour subtype. So we certainly do know that time to chemotherapy is more important in the triple negative subtype. Actually less so in HER2 amplified, but in the optimal care pathway, they group those together, and less important with regards to outcome in luminal disease or estrogen receptor positive disease. And you can see that we're not achieving that terribly well, even in the triple negative subtype, 35%. Neoadjuvant chemotherapy. So we were really excited that we could put together some data on how often neoadjuvant chemotherapy is being given across the state, given that we didn't think that that had really been looked at. Certainly individual institutions have looked at it and published on it, but not across the state. It is a bit of a surrogate how we've come to this data, so we hope this is fairly accurate, but I suspect there may be some small gaps. So the Victorian average says 11%, largely driven there by the SMICS data, but you can see a little bit of variation for neoadjuvant across the X. This probably is not surprising who's getting neoadjuvant treatment. And again, this is neoadjuvant chemotherapy, may well be HER2 targeted therapy in addition to that, but this is not capturing neoadjuvant endocrine therapy, although we don't use that all that often. So you can see that in about 1,000 patients, actually still 40% of them are in the luminal disease, whereas we tend to think of neoadjuvant in the more aggressive subtypes like HER2 amplified and triple negative. Radiotherapy data. We've got here the use of radiotherapy across the stages, including their DCIS. So 37% of patients diagnosed with DCIS receiving radiotherapy, and radiotherapy use not all that different between stage 1 and stage 2, going up a little higher in stage 3, which is unsurprising, probably regardless of the type of breast surgery, but probably due to the more locally advanced disease, and small numbers in that stage 4 and stage unknown. I think this is reassuring that the vast majority of patients are having their radiotherapy locally, so 84%. And our radiotherapists are doing better than our medical oncologists. I can say that because I'm a medical oncologist. They're doing better in terms of the timing of your treatment. So 66% of patients getting it 8 weeks and 100% of patients getting it by the 4-month mark. And in terms of hospital volume, you can see we've got the public on the left and private on the right, the private accounting for about 40% of patients treated, which is, I think, interesting. Again, I guess radiotherapy volume, we're really limited also to radiotherapy slides, a little different, I guess, to the surgical volume.
I know that some of the small volume ones are new sites, so they're probably
yes,
evening out a little bit more now.
So we have a little bit of data about survival. So this is data looking at 5 years survival across the ICSs, and the shaded area, I guess, is the average, looking at 5 years survival after a diagnosis of breast cancer. We're getting up over 90%, and that's certainly informed also as per the Victorian Cancer Registry. The only metastatic data we have is for those very small de novo metastatic patients. You can see that the vast majority of patients diagnosed with de novo metastatic disease are really well with very little other comorbidities, and a similar spread of socioeconomic status that we saw earlier. But I have to warn you here, the numbers are pretty small. For de novo disease, you can see it's not common to be diagnosed with a grade 1 cancer if you're diagnosed with metastatic disease, and a slight skew into the more aggressive subtypes, the HER2 amplified. The triple negatives actually didn't go up substantially, but a substantial number unable to be classified. And I think that talks to the data that we have around how these patients were diagnosed. And, for example, if you got a liver biopsy, was all that information captured and sent to the registry? Generally, survival for these de novo metastatic patients does not vary greatly across the regions. You can see there we've got, on average, 70% of patients alive at 1 year, and that falls to under 40% at 5 years. Again, I'll just highlight this is based on de novo metastatic patients, so a small subset of metastatic disease. In terms of supportive care, there was a medical record audit in a similar fashion with similar numbers to the MDM audit, so 465 patients. This was looking for a validated supportive care screening tool in the medical records, such as the distress thermometer and a problem checklist. And you can see there's some variation. The target here is 80%, and the average was just over half of patients. So some variation there. So we're at the summary slides. I think we feel that the incidence data, the subtype data, is fairly consistent with what would be expected at a national level. I think the incomplete staging and incomplete grading is of concern, and there's been multiple comments in the chat about that. The timeliness of care variations between the various local and systemic therapies working to the optimal care pathway guidelines, and those times from diagnosis to surgery to drug therapy, surgery to radiotherapy, or chemotherapy to radiotherapy. Mastectomy rates, 73%, and recon rates after mastectomy, 60%. Are these larger surgeries and more complex surgeries happening close to home? And certainly they are the majority of time for mastectomies, less so, but still for the majority of the time for recons after mastectomy. So the data gaps, we'll probably get more into this as we go through the day, but issues for synoptic reporting, the issues about neoadjuvant patients. We certainly have gaps around metastatic disease. We've got a very small snapshot of metastatic disease here. We certainly have been pleased that we've been able to capture some neoadjuvant data, and I think this will only get more common as Ian's commented in the chat. We're lacking drug information for the vast majority of patients treated for breast cancer, so we've got work to do there. And inconsistent use of the supportive care tool as per that screening audit that we saw. So some variations, the MDM participation rate, there were some variations from that audit, and we've discussed that, and there's been a little bit of chat, and we're going to talk about this in groups. I've already mentioned the supportive care screening tool and the timeliness to care. And I think this is a balance between the most important thing is getting the treatment plan right. And given how complex breast cancer treatment is, I would argue that time to make the right decision is more important than getting the decision within a specified amount of time. And obviously we haven't commented on, but certainly from the consumer video, we've seen that there's inconsistency with the way that information is given, and there's inconsistency with regards to coordination of care and who provides that contact and whether that changes with regards to the public or private system. Thank you very much to the department, to the registry data, especially Ella and Nora. Nora, you answered all of our complaints very well up until the last minute. So we really appreciate, we're really presenting your data. And thanks obviously to the Summits team and to Jane, my co-chair.